Okay, does anybody have any questions? We're going to go ahead and get started. All right, so what we have today, we're going to continue and finish the obstructive diseases presentation, and then we have another lab, a virtual lab, similar to yesterday, just different questions. And then we also have a midterm quiz that needs to be completed before midnight, but I'll just make that as a reminder before we start our lab activity. Okay, so let me go ahead and pick up where we left off yesterday. I have to apologize in advance. There's some construction going on in the neighborhood, and it can get kind of loud sometimes. Okay. So yesterday we did our case 2, and we came up with our interpretation that this looked like it was just exercise-induced asthma. And then we're moving on to what you would typically do if you suspect that the patient may have asthma. This is when they would do the pre and post bronchodilator. So you're the PFT technician and you're looking at the numbers and you're saying, wow, this looks like it might be asthma. So then you'll give the patient MDI like albuterol or bronchodilator, wait about 15, 20 minutes or so, and then do another test, do another forced vital capacity, blow, 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 take the best out of the 3. And then now you got some data to look at to compare before and after. And based on the gold standard, we're looking for a reversibility in the FEV1. It says FVC or FEV1, but we usually focus more on the FEV1. So if you notice that the post-bronchodilator FEV1 has increased by 12% or more and 200 milliliters, then that would confirm that this is just probably asthma, because asthma is the only obstructive disease that will show this kind of result for you as far as after the bronchodilator. The others, there may be some change, but it won't be this significant. It won't be enough. And that's, again, the gold standard when it comes to COPDers. They're never going to have this kind of a change. They're going to have maybe at best, they may end up with like a 10%, if that. But still, we just don't expect to see that happen for them. But asthma, yes. So now, how do we figure out this percent change? So we're looking at the FEV1 that we got after the bronchodilator, and then we subtract the FEV1 that we got before, and then just divide it by the before and times 100. So this percent change is represented here as just the plus 16%, plus 30%, et cetera, et cetera. So in this report, they did it for everything. They did it for the FVC, FEV1, the ratio, the FEV1 over FVC ratio, or FEV1%, and they also did it for the FPF 25-75%, which is the small airway parameter. But again, our focus is going to be mostly on this right here. And this was a whopping improvement after the bronchodilator. So we started off with the FEV1 was 3.55 liters before. And there was an 81% there was an 81% predicted for this 3.55 when predicted was 4.37. So wasn't that bad. So I don't quite know why they decided to do a post bronchodilator for this particular case, because these percent predicted all look good. Oh, I see. I'm sorry. Here's the problem right here. So although the FEV1 was normal, was just a little bit over normal, 80% or 81%, his small airways, that was the issue. This was only 50% of predicted. So again, this is what asthma is. Asthma is a small airway problem. So then the PFT technician decided to go ahead and do the bronchodilator. And then after, he still predicted on his FBF 25, 75% to have 4.74 liters per second of air leaving his small airways. And then after the bronchodilator, he went from 2.41 liters per second to 3.84 liters per second, which gives us definitely a much better percent, or at least a percent predicted is 80 now. And then that shows that there was a change of 59%. So this was a little bit different. So the problem wasn't with the FEV1 per se. It ended up being just a small airways. And I said yesterday that you would expect these numbers to kind of point to the same issue, that if your FEF 25, 75% is abnormally low, you probably would not expect your FEV1 to be normal. But in this case, this was the exception. So although this was only half of what it should have been, his FEV1 was still, he got out in the first second, just about. And I attribute that to his age. I mean, he's 26-year-old, and we don't know anything else that's going on with him. But chances are, at 26, you're not going to have any like other lung problems. You're not going to have any other like comorbidities, more than likely. Okay, and then the machine or the computer is also going to print out these loops for you, the flow volume loop. Now this is the opposite of the flow volume loop that we were looking at on the ventilator monitor. This is looking at, it's still flow, and instead of it being volume, it's just pretty much we're going to focus on the flow. So the flow is on the x or the y-axis, and the volume is on the x-axis. And this part down here is represented by inspiration. I found another color so this doesn't look like I'm trying to say. This is inspiration, and then this is expiration. So then the before is in red, and we see that his peak inspiratory flow rate was about close to 10 liters per second, which if you convert it to liters, would be 600 liters per minute. So again, he's probably fine. I mean, he's probably, you know, not having really any other issues as far as his health, except for his for the possible asthma here. And then he takes in a deep breath, and then the graph traces downward like this. And then they said, tell him to blow, 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 blow. So then as soon as he blows, this is his peak flow right here. This is his peak expiratory flow rate. This is PEFR. So his peak expiratory flow rate is about 14 liters per second. And if you convert that to liters per minute, it's 14 times 60. So that's like over 800 liters per minute. And then look what happens to the flow. So after he starts to blow as hard as he can, the flow goes from like over 800 liters per minute, and then it tries to drop. It's trying to do like a nosedive. I mean, as far as the flow rate is trying to stop. And what is happening is his airways are collapsing. And that's, again, that's the nature of lung problems, like airway problems. If you force the air out, they're just going to collapse. And the only thing that prevented this from not going from 800 liters per minute all the way down to zero is the fact that you told them to keep pushing and keep pushing and keep pushing. So then here it goes, you know, keep pushing, keep pushing, keep pushing, keep pushing and keep pushing and keep pushing. And then eventually at this point, his lungs are empty. And then they'll tell him to take another deep breath in. And then after the bronchodilator, we could see, although there wasn't that much more improvement in his peak expiratory flow rate, it's just a little bit higher. But look at the volume now. Look at his actual vital capacity. His vital capacity with the before was whatever this is. They don't have any. Oh, here it is. There's the numbers right there. So it looks to be about, there it is, about 5 liters, but it's right here on the chart, 5.2 liters. And then after the bronchodilator, he got about 6 liters, and there it is there on the chart, 6.06 liters. So this definitely improved his air trapping problem, because we could say that with the asthma, he was most likely air trapping, and instead of being able to get out the entire 6 liters of his vital capacity, he was only able to get out about 5 liters. With a bronchodilator, that made an improvement, so he was able to push all the air out, and then it got measured by the machine. And then the other graph right here is just a standard, like a volume versus time type of graph, and it's just showing you that the PFT technician did get him to keep blowing for at least 6 seconds, because again, that's kind of like the benchmark. Get them to blow, blow, blow for at least 6 seconds. So here we are, a 6-second mark on the graph, and you know he was able to go until about 8.5, 9 seconds before the bronchodilator. And then after the bronchodilator, a little bit lesser, but that is not relevant, because the fact is we still got to the 6-second mark there. And then another thing about this, it didn't take him that long to empty everything out after the bronchodilator. So it only took him about 7 seconds after the bronchodilator to blow everything out, versus almost 9 seconds before. So that's, again, air trapping and airway resistance. If you got that kind of resistance, it's just going to take longer to get the air out. And that's what's being represented here. So all of these things are looking like it all is happening the way it's supposed to happen. So he would be prescribed a bronchodilator. I mean, he would probably be, prescribed like a rescue inhaler, but then he'll be given a maintenance drug or something, steroids and things like that, so that he doesn't end up in a lot of exacerbations. Okay. So now with this case here, we don't have to calculate the percent predictors. They're already here for us. But we want to still go through the whole process. We want to take the before and identify what the problem is. Is this a normal person's PFT results? Is it someone who's got an obstructive problem? Or is it a restrictive problem? Okay, there we go. All right, so if we take a look at, if we're going to go straight to the ratio, his actual FEV1%, is less than 70. So we know that this is an obstructive issue. And then this right here, this is fine. That's 89% predicted. So with someone who's got an obstructive problem, they could have a normal FVC, or it could be abnormally low because of the ear trapping. And then we have the FEV1. So let me just do what we did yesterday and say that because 89% is normal, 80 to 120% is normal, then we say that just based on this one parameter by itself, without looking at anything else, who could have that kind of a vital capacity? It could be someone who is healthy, or it could be someone who's got an obstructive problem that's not significant as far as air trapping. And then the FEV1, looking at it by itself, it's 62% predicted. It's not normal, it's abnormal. So then who could have an abnormal FEV1? It could be, again, someone who's got an obstructive problem, or it could be possibly a restrictive. Sometimes restrictive patients do have lower than normal FEV1s, depending on exactly what their restrictive issue is. We've already done the ratio, the FEV1 FVC ratio, and then the only thing left here is the small airways, the FEF 25-75%, and that is definitely abnormal. So then who could have an abnormal small airway? And that could be definitely someone who's got an obstructive problem. And then just the way that we kind of tallied everything here, it's obvious that we got more O's than we have anything else. So this is a situation where our interpretation would be it's an obstructive problem, but then we have to classify how bad it is, whether it's mild, moderate, severe. And we go back to our FEV1. So for any of this, and once you've determined it is some type of obstructive problem, then we just go back to that. And now we take that 62% and place it into either the mild, moderate, or severe category. And 62% is going to be moderate. So we say that this is, I'll just write it, I don't have any room down here. So this is moderate obstruction. Was there any reversibility? If so, how much? So then we look at, we're just going to again focus on the FEV1 just to make life easy. And the FEV1, we don't use the percents. We don't use the 62% and then the 76% because that's not how it works. We got to calculate the actual measured values and see. So for the percent change, post-bronchial minus the pre, over the pre. And of course, this is all times 100. So that leaves us with a 3.2 post, 2.6 pre divided by 2.6 times 100%. $32 minus 26. So then we got 23%. this was a reversible airway problem. So again, we're looking at just run-of-the-mill asthma. Okay, so that's pretty much all there is to the pre and post bronchodilator. Now we're not going to have to do anything really with the bronchoprovocation challenging tests that they do, because that's just going to take a little bit more. As far as we can talk about what it's all about. It's all about trying to create a situation where the airways start to respond and start to constrict. So in other words, if you think that the airways are reactive, then you can give them the methacholine or give them like histamine, nebulized methacholine, or some other kind of like derivative. And if your first dosage doesn't cause, at least because you're looking for about, I think most labs use about a 20% drop in FEV1 after the methacholine or whatever it is that you're giving them. If you don't get nearly that much after your first dosage, then you're expected to double the dosage and try it again. And if you still don't get your FEV1 to drop by about 20%, then you'll double the dosage again. And then there's a cap. You're only supposed to go to a certain dosage. And if you haven't gotten at least that kind of a drop in FEV1 after you've maxed out on your medication, then you won't be thinking that this is asthma. Because if it was truly asthma, it would have probably responded very early on, maybe after that first dosage, or definitely probably would have responded after you had to double that dosage of the drug. Okay, for which one of the degrees of it? Always use the NBRC, because NBRC is trying to make it simple, because you had to use that same classification for oxygenation. And so it works just fine for PFTs as well. In the hospital, they use the ATS. So the PFT labs use that. But for your board exam, they use, what's that? The slide we're looking at. Oh, I see what yeah, I'm sorry. I'm not paying attention to what I'm doing here. This is mild. That's my fault. I must have looked down at the FEF 2575 when I wrote the moderate. But yeah, we're using that same 60 to 79 is mild, and then 40 to 59 is moderate, and then anything less than 40 would be severe. So thanks for clarifying that, because if anybody wrote down moderate and felt that was not right, then it wasn't right. Okay, so any other questions about the where do we comparison for reversibility? We're looking for if percent change for FEV1. Now the gold standard will say FEV1 and FVC, but again, we can just focus on the FEV1, because that's what the NBRC usually does, is they just kind of focus on just this instead of both. So if the change for the FEV1 is greater than 12%, this confirms reversibility. So we say greater than 12%, and I also need to include the 200 milliliters or 0.2 liters as well. So greater than 12%, and let me erase this because I want to make sure greater than 12% and greater than 200 milliliters. These confirm reversibility. So now let's look at the FEV1 before. FEV1 before was 2.6 liters, so 200 milliliters, 0.2 liters. It was 2.6, so we're looking for this to go up by at least 0.2 liters. And it did. It went from 2.6 to 3.2. So that was way more than 200 milliliters. This was 600 milliliters or 0.6 liters. Okay. Any other questions about the pre and post bronchodilator? So if you're ever asked or given a question about it, that's what they want you to look at. They want you to look at the easiest thing would probably be the first to just check for the 0.2 liters or 200 milliliters. Did FEV1 increase by at least 0.2 liters? And then you look, and then you can look at the percent change, because again, they both should, if the FEV1 went up by more than 200 milliliters, then it should have also been more, it would have been more like it would have been 12% change. It should have been. Okay. All right, now, so here we are with our obstructive diseases, and we're looking at the same kind of pattern, especially when it comes to our PFT results. The numbers are all going to kind of look the same way as far as the problem that they have is always with getting the air out and air trapping. So we have the cystic fibrosis and chronic bronchitis, asthma, bronchiectasis, emphysema. And then sometimes people don't add the bronchiolitis, and that's mostly like with kids, but it still makes the same kind of acronym. It's still CBABE or CBABE, if you want to emphasize the last B. So then we'll start with cystic fibrosis, and of course, this is out of all of the obstructive diseases. This is the one I would probably say is pretty bad, but they're all bad, and this is one of those things where you just never know. If you don't know what's going on with your genes, like if you're a couple and you're planning on having kids, sometimes parents will get a genetic screen just to kind of see if there are any markers, anything that would possibly lead to them passing on something, and then it ends up with the child possibly having some kind of anomaly. Now, cystic fibrosis, the chromosome 7 is the gene that's affected, so it's the CFTR gene, or cystic fibrosis transference membrane regulator. And because of that malformation or that deformed gene, then your cells are just not able to transport the chloride across the membrane like it's supposed to. Chloride and sodium together make salt, as we know. And so that means that there's always going to be that problem that they have with just the mucus that's just piling up and is very sticky, extremely, extremely sticky. This mucus is so sticky, your basic mucolytics are just not enough to break them down, which is why they have to have the Dornase alpha or the pulmozyme to attack that mucus at, at a different, well, it's breaking down. I'll talk about it when we get into the therapy options here. But let me write that cystic fibrosis, this is out of all of the CBAGs, the only one that will have another name as far as, when you break it down as far as the medical, what's going on, it's mucoviscidosis. So our osis, as we know, that's the condition or state of. And then muco is mucus. And then visci, this is the problem. That mucus that they're producing is so sticky and so viscous that it's creating all kinds of problems with all of their body systems. It's clogging up everything, essentially. And again, because it's a recessive trait, that means that your children, there's a 1 in 4 chance that they would end up with cystic fibrosis. And we know how genetics work. This doesn't mean that the 4th child that this couple has will have cystic fibrosis. The first child that they have could have it. It's just like Russian roulette, or just, you're spinning the, whatever I'm trying to say here. So you're gambling is what I guess I'm saying. You just never know. Second child may end up having it, or whatever. Now, so what do we expect to see happen in cystic fibrosis? And we know that it's around the clock, 24/7, that they're producing all of this really thick, viscous mucus. And this is going to be their challenge, is to try to keep their airways clear as best as possible. So it's like pretty much overactive. You got too many of these glands, first of all, and they're all just producing this stuff. And then that CFTR mutation, that's making matters even worse. Partial or total obstruction just means that the airways can be pretty obstructed with this mucus if they're not able to clear it, or it just may create like partial obstructions, which could lead to like the ball valve effect that we looked at with meconium aspiration syndrome. So we're going to keep seeing this. This is, again, the classic PFT findings for all of these obstructive diseases. So the increased FRC is the air trapping. The increased TLC, that's air trapping. The increased RV, that's air trapping. And when we say increase, we're looking at normal range in PFT. All parameters except for the FEV1 FVC ratio. Because we use 70% for that one. So normal range for all parameters would be 80 to 120% of predicted. So I said this yesterday, if you're healthy and you don't have any lung issues, you'd expect things to be like 100% of predicted. I'm pretty close to it, maybe a little bit less, or maybe just slightly more than 100% of predicted. But if you're dealing with someone who's got extensive lung damage, like cystic fibrosis or whatever, FRC would not be 100%. It would be leaning more toward like the 120%. And in some cases, it's even more than 120. It could be like 128% of predicted. But that's screaming air trapping. The same would go for TLC. Why would your TLC need to be more than normal? Unless you're holding on to a lot more air than you're supposed to. And the same goes for RV. Why should your RV be over 100%? But again, these are the patterns, and this is the classic finding with a lot of these air trapping type of problems. And then the FEVs, like the FEV1 that we've been looking at, you can't get the air out fast enough. So in that first second, instead of getting out a certain amount, you only got out maybe half of that, or maybe even less than that. And that's again the extreme air trapping and air resistance problem. So they can take in the deep breath, but they just can't get it all out, or they have a hard time getting it out. It takes a long time to get the air out. And then one more comment about this normal range for the PFT parameters, it has to be 80 to 120%. We can't just say normal is 80 to 100, like we do with like blood gases and oxygenation. It has to be more than 100, because for some parameters, that would tell you something. I mentioned that pretend that your peak expiratory flow rate on your report showed that it was 115% of predicted. Now you would be jumping for joy to say like, wow, this person did a really good job. And you only expected them to do 100% predicted as far as getting the air out, as far as how fast they can get the air out. But if they did more than 100%, then that's pretty convincing that there's definitely no problems there. But again, that's just looking at like peak expiratory flow rate or FVF 200, 1200. You know, if it was more than 100%, then you would be saying that's definitely not a problem. But for these, like the capacities and the residual volume, that's air trapping. All right, and then we continue. Again, all of the body systems are going to be affected by this mucus. It's clogging up every duct, every passageway you can imagine. And so when we think about what's going on with the GI system, this is the gallbladder. This is the duct to the gallbladder. So here's our gallbladder, and we know the gallbladder is dumping in So we know the gallbladder is going to add some bile to take care of the fat and everything else that you ate. This is the stomach. And then this is the pancreas. So the pancreas is trying to dump some enzymes into the stomach to break this food down and digest it. So then here's the problem. Everything is just getting clogged up. So that means that these patients who have cystic fibrosis, they have a really, really, really hard time gaining weight. They're usually pretty skinny, no matter how much they eat. And they have to take like all these multivitamins, and they have to take enzymes and things like that. So sometimes that does help, but not always. Their diet is usually amped up, meaning that they have to take in a lot more calories, way, way more calories than normal, just to have a chance at getting some of that to be absorbed into their system. Because again, without the enzymes from the pancreas, all you have to break down your food is the stomach acid. So cystic fibrosis isn't really interfering with the stomach acid per se. It's the enzymes that can't make it there. And your stomach acid can only break down the food so much. Enzymes are going to be necessary to definitely take care of the rest. And the same goes for the bile from your gallbladder, especially when you're eating like a lot of fatty foods. Now, the signs and symptoms, I mean, it is going to be a comprehensive body system kind of issue that they're going to be experiencing. So way, 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 way back in the day, I'm talking like ancient times, cystic fibrosis has been around forever. And way back then, parents were concerned that something was not right with their babies when they would say, like, kiss the babies, if they're kissing the baby's cheeks, and if the baby's been crying. Now we know that there is a certain amount of salt that's in your tears, but if you kiss your baby's cheek and it tastes like somebody literally just poured a box of salt on the baby's cheek, then that's got to be a red flag that something's not right. So salty tasting skin is something that you'd expect to find. And of course, the lungs are just going to be always, there's always going to be some mucus retention going on, or secretion, retention. And anytime that you can't clear out all of this mucus, that's just going to be a breeding ground for infection. So they end up a lot of times in the hospital over and over again because of their lung infections. But they're taught to try to do the best that they can to keep mobilizing this stuff at home and coughing it out and getting rid of it so they don't end up with some kind of infectious process and they have to end up back in the hospital. So the child is probably not going to be in his correct growth percentile. And this is going to lead to a lot of just stunted growth, and overall they're just not going to really pick up weight because they can't digest their food completely. And then the ileus, again, everything is just pretty much getting blocked. And then they also take on, as we know, say you've got a child who's been dealing with cystic fibrosis for a while, and now with our better therapy options that we have, these patients are now living longer, because before it wasn't really expected for a child to make it really past childhood. And then as we got better with our advances and medicine and that sort of thing, now it wouldn't be uncommon to find somebody, as long as they've been taking care of themselves, to be able to make it to their 40s. I remember a patient who, he was a paramedic, and he was just waiting for a lung transplant, but he ended up in our hospital, not often, but I guess he would maybe a couple of times a year. But the first time that I had him as a patient, his name was Jake. The first thing that I remember was he had junk food from one end of the room all the way to the other end of the room. It was just like, it's almost like walking into a convenience store where there's just a bunch of, there's cookies and there's candy and there's everything. And of course he was skinny. I mean, he wasn't really, he was just trying to eat as many high caloric type foods as he could, just to try to get some calories. Now, he had the classic barrel chest, and that's something that we expect to see with these obstructive diseases. So he had a barrel chest. So let me write that as well here. They usually have like their abdomen is kind of protruding. I'll just write protruding abdomen. And over time, when you're hypoxic, say this mucus is always clogging up your airways, and that's interfering with gas exchange, and you're hypoxic. So long-term hypoxemia leads to hypoxemia. There's going to be some clubbing going on. Digit clubbing, fingers and toes. And again, it's just, it's not a good, nothing's really going to be good as far as the body systems go. And protruding long-term hypoxemia and infertility. So that same very sticky, thick mucus will typically clog up the vas deferens. so that, the man is not able to fertilize the egg. And then the woman, if she's got cystic fibrosis, that mucus is going to clog up the fallopian tubes in some cases. And even if she did conceive, it would be extremely, extremely, extremely risky to try to carry a baby with these kind of issues. And no matter how well you're able to keep up with like your CPT and everything else, it's still, I mean, you're just not, it's not going to probably work out. Now, just what happened with the patient Jake, his girlfriend told us that he did eventually qualify, or he got accepted to that whatever program that he was trying to get into to get a lung transplant. Was really long and hard. It's like a 2-for-1 kind of thing. But once they do get their lung transplants, then they usually are okay. Now, how do you diagnose? I mean, most times they're going to just do a simple sweat chloride test. And here's some values. There normally should be about 10 to 35, but in cases of cystic fibrosis, it would be more than 60. And that's the threshold that they usually look for. And the sweat chloride test is not very sophisticated. It's just a matter of just making the skin sweat, just placing an electrode, a little patch on the skin, and then just collect the sweat. So the electrode is just going to stimulate your sweat glands to produce more sweat. And if they didn't have the electrode, like say it's a newborn baby that they want to test, they didn't have the electrode, they could just literally take some saran wrap and wrap it around the arm and get it to start to sweat. Because all you really need is just a sample of the sweat to send to the lab. And then they could also do a genetic screening. They could check to see, they're looking for chromosome 7 to see if there's any mutations to that one. And then of course they look at what's going on with the family. Again, being that this is like a 1 in 4 chance, they'd have to look into that as well. 18. I mean, there's so many other things that we could probably write as far as their signs and symptoms, but these are going to be probably the more common things. Because again, this is a multi-system type of issue, okay? This is a multi-system kind of issue that they have to deal with. And then this last point right here, this is usually what the process is going to get worse over time. So it's a debilitating kind of thing, but you usually can slow the progression by, taking all your medications and trying to, live as healthy of a lifestyle as you can. And that usually does wonders for slowing these things down. But let's say that you have it so bad where you just can't keep up. You're always like congested with all this mucus and you can't really get it out like you're supposed to. Then that's what will usually do you in. It's these recurrent infections that they get over and over and over again that will usually lead to what they call failure to thrive. Now, anybody who has this disease will be taught how to do their therapy. And that's usually where you're going to come in, especially in the hospital. If they just newly got diagnosed with this, you're going to do a lot of training and education with them to help them with making sure that they can mobilize this stuff. Breathing, if it comes down to breathing exercises or definitely like how to do proper postural drainage and percussion. Now they're going to mostly have, I'll talk about it when we get into the treatment options. So the x-ray, it really depends. Now the x-rays are not always going to be able to show you the problem. And in fact, most radiologists will say that the x-ray is kind of lagging. It's always like, here's the picture of the x-ray, but the problem is not going to really show up yet. Maybe on the next few x-rays in the future, it might show up, but they don't just look at that x-ray and say, that's it, I can see it. This is definitely cystic fibrosis. So, but with this film, you might see dark, like there's translucent areas. I mean, there could be more translucency than usual, more radiolucency than usual, which would mean air trapping. And then your diaphragm, it's going to be more flattened out than usual because of the air trapping. The right ventricle could be hypertrophy. Now, the right ventricle on this particular x-ray doesn't look to be hypertrophy. So again, you just can't always count on your x-rays to show you all of their problems at that particular time. But if they do end up having this right ventricular hypertrophy, it does usually show up like very late on. I mean, if they start to get, again, worse and worse over the years, then that's when these kind of things might show up. Now, in addition to the air trapping, there may be some areas of atelectasis. And then I guess this is just kind of like the problem with the constant mucus that's being produced and they can't get it out. And it leads to certain areas of the lung are just going to collapse because of the blockage. You can't get the air there, the alveoli are going to collapse. And then there's like, this is like a constant process where there's like inflammation and then there's some healing. And anytime tissue heals, it leaves a scar, whether that's your skin on the outside, which will be obvious, it's noticeable that you had an injury, it healed, and now what's left is, you had a scab for a little while, and then when the scab fell off, you notice that there's a scar. So internally, it's the same thing. You've got inflammation, then you got some healing, and then you got this scar tissue or fibrotic tissue that's left behind. And it just repeats over and over and over again. So this is the fibrosis part of cystic fibrosis. Now, this isn't necessarily pulmonary fibrosis, but their PFTs can show both. It can show the obvious, the air trapping, the obstructive problem, and it can show the restrictive as well. Now we're on to the B, bronchitis. So bronchitis, we know we've probably all had acute bronchitis at some point. And that's not a concern because it usually goes away. But if it's a chronic problem, then that's when you're going to have some noticeable changes going on with your lungs. So some of the general reasons why patients will end up with chronic bronchitis is, of course, smoking. So smoking is kind of like right there in the center. And this is not necessarily just you smoking, but maybe you're around people who smoke. So the secondhand smoke is going to be problematic. And that's why they say, parents who smoke in the house with their young kids, look what you're setting them up for. It's like, I don't get it. I don't get it at all. And I say that because I have a sister who used to do that. She used to smoke in the house with her young. And luckily, her daughter didn't grow up with any problems, any lung problems. But, and then, of course, the infections, if you're getting upper respiratory infections all the time, over time, that could possibly lead to some issues. And again, your house, like you may be living somewhere next to a manufacturing plant or some kind of processing plant. And again, I'm not trying to be funny here, anything like that, or try to downplay any area of the city, but I just feel bad for people who have to live like Benicia with that, what is that? Is that a paper mill plant or whatever that is that is always producing this stuff in the air? And any kind of like irritant that you're inhaling over time is going to lead to this problem as well. Or refinery. Okay, yes. So any kind of like if you're near those kind of places where it's like what do you do? I mean, you have to have the refinery, but it's always going to be producing this stuff that's going to end up being in the air that you end up breathing. And the same would go for, I guess, people have to live next to the airport. So it's kind of like you try to get them to address it, but then what can you really do? There's not much. And your only solution would have to be maybe I got to move because the refinery's not going to move, the airport's not going to move. And then we could also add GERD. Let me add GERD in here as well. So reflux disease. If you've got somebody who has a lot of acid reflux over time, that acid will make its way into your lungs. And this is usually not obvious when you sleep at night. That's probably prime time for people with like GERD to have they aspirate some of that stuff. All right, so then this is specific. So with chronic bronchitis, you have to kind of like fit this description right here. They're going to do, of course, they're going to ask you questions, and these are the things they're looking for. Well, first of all, have you been coughing a lot? And if so, have you been producing a lot? Because all lung diseases are not going to be productive, but they're all going to have some kind of cough involved, but they're not going to always be productive. So you're coughing and you're coughing up stuff, and you don't know where it came from. Maybe it just kind of like started to happen, and you don't know quite why. And then it has to be for 3 consecutive months that you've experienced these kind of symptoms. And it has to be 2 or more years of that process. So in other words, all it really has to be, so maybe it's been happening over the last couple of years. And as long as you've had 3 straight months where you've just been waking up in the morning, coughing up this really gray looking foul stuff, then that's when they start to looking to possibly this is maybe chronic bronchitis. Okay, well, looks like it's break time. So let's go ahead and do a 10-minute break and then we'll come back. Okay, I'm back. Now, I see that there were a couple of questions in the chat, but I didn't see them in our group chat. So I'm only got my page open to the group chat, but I noticed that a couple of people had sent a message through their individual groups, like when you're in your labs. So that's the thing about Teams. It'll keep track of every conversation that you've had, but it will only show you one stream at a time. So I just see like a little icon that says I have a new message, and then I have to go look to see which streams. I got like tons and tons of different streams here. So yeah, just be sure that we're posting to our group chat. So that way, as I look over, I can see when a question comes up. And one more thing I realized, we're talking about chronic bronchitis, but I don't remember seeing anything about the treatment options for cystic fibrosis. Let me back up here and see if I maybe missed something. So there's our diagnosis, signs and symptoms diagnosis, chest x-ray. And yeah, oh boy. Let me just write here because we jumped right into we went right into chronic bronchitis and didn't talk about our treatment options for cystic fibrosis. All right, so let me say treatment option. They're definitely going to need to have a lot of chest percussion. So we're going to do a lot of chest percussion. And that could be you teaching them how to do the percussion manually with the hands, or their insurance usually reimburses them for the chest vest, like the oscillating vest that you plug in, and so we got that, some kind of chest percussion therapy, lots of it. And then we're going to need to have a lot of antibiotics. So a lot of those antibiotics are going to be nebulized, and then they're also going to be taken, if like say this is someone at home, they're going to be taking oral antibiotics as well. In the hospital, it'll be the same thing. You'll be nebulizing certain antibiotics for them, and then they'll be getting other antibiotics, usually IV. So they're going to need definitely antibiotics. They're going to need bronchodilators. And you're going to need mucokinetics. Now, mucokinetics is a broad category, meaning that you've got different drugs that you can give, and in their own way, they're going to make the mucus start moving. Whether that's breaking the mucus down and making it thin and watery, or just affecting the mucus in some other way to make it end up leaving the airways, or making it easier to move out of the airways. So our mucokinetics, and we know that could be Dornase alpha or Pulmozyme. And they could sometimes they'll prescribe just regular saline to kind of like hydrate the mucus and get it to move a little bit easier. Sometimes they may prescribe sodium bicarb nebulized. So they'll take a nebulizer treatment with just sodium bicarb, because the sodium bicarb will change the pH of the mucus. It'll make the pH more alky. And anytime the pH of the mucus becomes too alky, it starts to break down. So that's another way of kind of getting it to become more like watery. And I mentioned like some mucolytics, like Mucomyst, is usually not strong enough, which is why they reserve the Pulmozyme for that reason. The Pulmozyme will break down the all the genetic material. So as the bacteria, as they're having these bacterial infections, some of the bacteria, of course, is going to end up dying. And any bacteria that's just still hanging around in the mucus, it's just all more stuff. It's like the genetic material of the bacteria is just kind of accumulating in the mucus. And then that's what's changing the viscosity of the mucus. That's what's making it extremely thick and tenacious. So the Dornase alpha will target all of that DNA that's left behind from the dead bacteria, and it'll break that down and make it easier for the mucus to start moving again. And what else are they going to need? They're going to need some steroids for the swelling, because again, the fibrotic process that's happening, that's like that's an immune kind of thing that's going on. So they're going to need steroids for sure. And I mentioned that they're going to have to take some supplements, so they're going to have some dietary supplements. And that could be just your pancreatic enzymes, your vitamins, and what have you. And they're going to tell them to of course, take in way more calories than usual. So dietary supplement. And what else are they going to prescribe for these patients? Exercise. Now, exercise, as we know, is going to help to mobilize stuff. I mean, it's going to help you you may start coughing, and it's just going to make it easier for things to start to move around. This will be definitely relevant for kids. You're going to want to have your kids to try to be as active as they possibly can. Now, these treatment options, it's going to vary depending on just how bad the cystic fibrosis is. Sometimes they may have to do a whole lot more and have to be very aggressive. And other times they just don't have to be as aggressive. And they don't have to usually have every single option being implemented. And then they're also going to need they're definitely going to need some psychosocial type of support. And with someone newly diagnosed with this kind of debilitating disease process, you can imagine how that's going to take a toll on them, and especially when they learn all of the ins and outs as far as what's going to happen and what they're not able to do, especially like they're not going to be able to have kids, and just having just any kind of like social life, how that's going to be impacted. Now, the saddest thing is when you have a child who has pretty bad cystic fibrosis, and this child is not even able to go and do like sleepovers with their friends, because the liability, parents are not going to be happy with having a child stay over who has to do all of these things like on a regular basis. They've got to take their nebulizers, they got to do their CPT, they got to try to like clear all this stuff out. So you can imagine these parents would be scared to say, I don't want that to happen in my house. Something happens, something bad, and it's just too nerve-wracking. So these kids, unfortunately, they just can't have like a normal childhood, and that could be tough. So that psychosocial support is extremely important. And then with all of their drugs that they're taking, like all the nebulizers they're taking, because of the concern that we always have for the infections, we have to be teaching them to be very careful with their equipment and clean it after each use. And we also don't really mix their meds together. Like some of these drugs will probably be mixed together when you nebulize, but they are usually taking them individually. So they have to have a separate nebulizer for each medication. So then what your treatment load would look like if you've got, say, a patient or two patients with cystic fibrosis, you would be given those two patients and maybe one more, and that'll be all you could handle because of all the steps that you're going to be expected to take. You're supposed to give each one of these nebulizer treatments individually. And then after, you're supposed to do the CPT and postural drainage. And then you give the next one. And then you do more CPT and postural drainage. And then you do the next one. And then you do more postural drainage. So it could be that they would have a bronchodilator that you have to nebulize. They could have the antibiotic that you would have to nebulize. You have to nebulize their pulmozyme. You may have to just nebulize just regular saline. And you may have to nebulize a steroid for them as well. So that could be 5 individual nebulizer treatments that you'd have to give for that round, for that one particular patient. And there's CPT and postural drainage in between each one of those. And then afterwards, you're supposed to drain, or you're supposed to clean out the nebulizer and then let them air dry. Place them somewhere where they can air dry, so that way there's nothing left over when you're ready to go back and do the next round of treatment. And that could be very, very time consuming. So again, if you get assigned 2 patients with cystic fibrosis, they're going to keep you busy. Your first rounds may overlap into your second rounds. Now, and one other thing about when you get those patients, they usually are pretty good with their regimen, and they'll instruct you or they'll guide you on what needs to be done because they're so accustomed to doing it the way they're supposed to be doing it at home. So when they're in the hospital, they're going to pretty much let you know, I do this first, then I'll do this, then I'll do that. Then you need to do this, and then et cetera, et cetera, et cetera. Okay, so that's cystic fibrosis. And now we can go on to chronic bronchitis. And I've already mentioned that this is the diagnosis here, the 3 consecutive months or 2 or more years straight. Now, what's happening with chronic bronchitis? Again, we've all had acute bronchitis at some point in time. But the chronic bronchitis is just, you got the swelling that's happening, of course, more than normal, more than usual. And with any kind of like swelling like this, you're going to end up with bronchospasm. Of course, your airway is getting smaller and you're going to produce more mucus. So you've got more of these little goblet cells that are being produced, and then you're going to have more mucus. So it just means that they're going to end up with the classic kind of like mucus plugging that's going to lead to all of the air trapping. And then over time, they could end up with some heart problems as well, like the right side of heart failure, or cor pulmonale is what they will sometimes end up with as well. Now, the signs and symptoms, well, the first thing is, let's just talk about the nickname. Anybody with chronic bronchitis will usually be referred to as a blue bloater. And blue because of the fact that there's definitely going to be cyanosis. Even if the cyanosis is not that obvious, if you don't really see it like in the arms or in the chest or wherever, you will definitely see it around the mouth area. The cyanosis is because of this. And I'll talk about that as I go down the list here. So vital signs, when you take the vitals for someone with chronic bronchitis, you wouldn't expect them to be completely normal. So you may have some tachycardia, and you may have definitely some tachypnea as well. And blood pressure would probably be elevated. Now, as far as the blood gases go, if you were to get the blood gas, then you would probably see like a type 2 type of pattern, like a hypercapnic respiratory failure, or a chronic respiratory or chronic ventilatory failure type of ABG, where they've got some bicarb now compensating for the fact that their CO2 is so high and it's been high for a while. Now, the polycythemia, this is in response to the O2. As we know, in order to try to increase your carrying capacity, you got to have more red blood cells. And that's the problem. When you got way too many red blood cells, they all can't fit through the capillaries at the same time. It's almost like, you know, like you got 10 lanes on a freeway and there's cars in every lane. Each car is hemoglobin. And then you're all trying to get to the same place, but then all of the lanes end up converging into just one lane, which would be like your capillary. Your capillary is only able to handle one red blood cell at a time, and they have to be like single file. So you can imagine with all these extra hemoglobins, even though they're transporting oxygen, they're all going to start clumping together at these capillaries, and they all can't get through. So then what you end up with, you still end up with cyanosis. And then the barrel chest, that's of course just the classic increase in the anterior and posterior diameter because of all the air trapping. You're just going to physically see that kind of a change happen over time. And with the peripheral edema, that's usually again associated with the heart failure problem. So blood is now pooling in your peripheral extremities, and especially like in your feet, you're just having a hard time getting all of that fluid to return back to the heart, or to the right side of the heart. Purulent sputum is definitely the word for the stuff that they cough up. It looks foul. It looks pretty nasty. So purulent sputum is in itself telling you that there's some kind of infection going on. And as we know, sputum is only supposed to be clear. Anytime it starts to take on any kind of like gray or brown or yellow, green, and you name it, then that's got to be a problem. And then with the pursed lip breathing, that's instinctive. No one has to teach you how to pursed lip breathe. You'll just automatically start doing this. But we will re-emphasize this when we're trying to educate these patients, just to make sure that they remember and to make sure that they're doing it the correct way. You can use the pursed lip breathing method to help anybody calm down. And this doesn't necessarily just have to relate to someone with lung disease. It could be someone in the ER who's freaking out, and you're trying to get them to maybe try to slow the breathing down. Because if you get an ABG for someone who's panicking, you know what the results are going to show. It's usually going to show a respiratory alkalosis. So if you want to try to get them to slow down, if all possible, teach them how to do the pursed lip breathing. And then they'll just have to focus on the breathing. And that means that you can't be tachypnic and pursed lip breathing at the same time. It just doesn't work like that. Okay. So one other thing about the blue bloater, they do typically end up being a little bit overweight. And overall, the metabolism is not that great either. So now, how do we treat these patients? And we start looking at the drug options that we have. You know, they're hypoxic, so O2 is definitely needed. They got bronchospasm, so we're going to need to think about albuterol or Xopenex or something along the line, some kind of beta adrenergic. The mucolytics, so this would be like, you know, just basic mucolytic, not like a Dornase alpha, but just like a Mucomyst would be fine for them, or just bland aerosol will help to mobilize the secretions as well, and steroids and antibiotics. And then because of all the edema that they have, they really could benefit from having like Lasix, any kind of like diuretic, really. Bronchial hygiene, some of the pulmonologists still will write orders to say pulmonary toilet. So just so that you're not thrown off if you're looking at a patient's chart, and if they write Pulmonary toilet. That's what they're referring to. Just means that they want you to use whatever tricks that you have, whatever techniques that you have, that's going to help to mobilize this mucus. And that could be, again, just breathing exercises. It could be posture drainage. It could be whatever the case may be, using like a flutter valve, et cetera, et cetera. Pulmonary rehab is helpful, and they should be able to qualify for pulmonary rehab. One of the things about rehab is they have to have already done certain things. Like they had to have already had certain tests done. And one of the major tests that would need to be done would be a complete PFT. So they have to have those results on file before they would consider a patient for pulmonary rehab. The graded exercises, once they do start rehab, is going to help to increase their endurance, because there's many options, there's many types of machines, and there's many kind of exercises that you can have them do, where you can, over time, as they get stronger, increase the intensity, make it a little bit more challenging, or increase the duration. Like treadmill, classic. You start off with going very slowly, get them just to do maybe like 5 or 10 minutes. And then a week later, they've probably now gotten a little bit more conditioned, and now you can speed it up. Or now you can add an incline, or now you can make them go a little bit longer. And it's just like training for anything. Like, as you start off, you're going to not be that good. But then as your body gets more conditioned, then you can now do a little bit more. You go longer and you're stronger. So that's the whole point of a graded exercise. It's just to help them to get conditioned and do it slowly over time by changing the effort on the machine. And then breathing exercises and education is always the big components of pulmonary rehab as well. Now, asthma. Now, we know that asthma is a two-part problem. It's an allergic response, and it's also bronchospasm. And those two combined could be always the problem when there's an exacerbation. It could be some kind of response they're having to their environment, maybe. So we got the intrinsic versus the extrinsic. And with extrinsic, of course, you would have to probably see an allergist, and then they would do like the test, the skin test, put the things on your skin, prick your skin, and all that stuff to kind of see if you have any response to it. And then the intrinsic would be, maybe it's not something in the environment, or maybe it's not something that you're eating that's triggering your body's response, but it could be, maybe it's psychological. Maybe it's your hormones, or you're stressed out, whatever it may be. Now, the extrinsic asthma, it's pretty clear that if you're in an environment where there's a lot of dust and there's like pollen season, like right now, anybody out there who suffers from allergens, what am I trying to say? The pollen is something that's going to get a lot of people. And if you have asthma, this is going to be even worse. So moldy houses, it seems like every time you turn around, you hear somebody saying that, like, I got an apartment, and once I got into the apartment, I found some black mold, and the landlord didn't want to address it, but that's a health concern. The dust mites, this is just a microscope. This is like a microscope. This is like a scan. I can't get the words together for whatever reason, but you can't see these. These are what's feeding on our dead skin in our mattresses. So they say that after so many years, your mattress is so full of these little dust mites that it's all them and no more mattress just about. And I guess a good rule of thumb is you should be thinking about getting a new mattress after about, what do they say, about 8 years or so? Because these things, if you had never been allergic to them before, the dander that they're producing is going to sometimes trigger your body. And we know when it comes to any kind of antigen, your body will tag it the first time around, and you're not going to have any kind of symptoms. It's just going to kind of like place a little marker to say the next time I come in contact with this, then I'm going to release all of these mediators into the bloodstream, and then you have your full blown type of response. Again, et cetera, et cetera. Cockroaches and like not just inner city problems. It could be anybody who has these kind of issues. It seems like every time I read about issues with people and cockroaches and it's causing, asthma type of symptoms and their kids and whatever, it's usually like New York. And New York is just unfortunately extremely overcrowded. And then et cetera, et cetera, et cetera. As we know, this list can go on and on and on. You may never know exactly what it is that's triggering this kind of response. Again, the intrinsic, and it may not be that obvious. It could be anything. It could be a food allergy that's causing you to have wheezes, or again, it could be that you are just under a lot of stress and now you start wheezing. All right, so as far as the pathophysiology, it's not that complicated when it comes to asthma. You end up getting exposed to something like one of your triggers, whether it's something that's considered to be extrinsic or intrinsic. And then your body goes into, it now recognizes whatever this is as being a problem, as being foreign. And the goal is now to try to like flush it out of the body. And the way that it will do that is, it's going to release all of these things like histamine and leukotrienes and prostaglandins, and all these things are being released so that way you end up with more blood flow to certain areas. And unfortunately, it means you're going to also have some constriction going on, like your small airways are going to start to constrict in response mostly to like the histamine. And you're going to have, of course, more like you're going to be producing more tears. You're going to have like your eyes are flooded to try to wash out this stuff. Your nose is going to start dripping to try to flush out this stuff, and et cetera, et cetera. And then with asthma, you don't typically expect to see pureness sputum with asthma. Theirs is usually described as more like whitish, or if anything, they'll say mucoid type of sputum, but it's not going to look like somebody who's got, say, like cystic fibrosis or chronic bronchitis. And then it could take on the air trapping, and again, if there's enough mucus and it's not leaving, then it could lead to atelectasis. All right, and then the signs and symptoms. What do you expect when you're in distress? You're going to expect to see an increase in pretty much all your vital signs. And the breath sound, wheezing is usually at the top of the list. You expect to hear some wheezes with the airways being constricted like this, but it could also be maybe just, rails that you're hearing, like there's just rails instead of wheezes. And maybe diminished or maybe absent. Now, a word about diminished or absent. These findings after the bronchodilator should be of concern. And what I mean by this is, let's say you've got a child who's clearly having an exacerbation of asthma. At first, you're hearing a lot of wheezes. You're possibly hearing it on inspiration and expiration. So they're working really hard to try to get the air in and out. You hear the wheezes, and then you give your bronchodilator. And then after, you don't hear any wheezes anymore. Instead, you hear like nothing. Now that should be a red flag. Like, what should you have heard? What you should have heard was, if the medicine is really working, the airways should start opening up a little bit more. And wheezes will take a little bit of time. I mean, they'll go from like a high-pitched wheeze to a lower-pitched wheeze. A lower-pitched wheeze kind of sounds like rouse, but they say it still has like a musical quality to it. So in other words, if this child's breath sounds after the treatment sound louder and more rough, that's a good sign. But if you don't hear anything, don't be convinced that he or she's better. And in fact, it might be getting worse. So that's what the ER physicians will usually ask you. Like, you've got a patient in room, whatever, and they've got, of course, they got exacerbation of asthma. You give your bronchodilators. They may ask you to do like 3 back-to-back, or they may ask you to do a continuous NEB treatment. And then the physician will ask you, is the patient doing any better? Because they're trying to see whether or not they can discharge him. So they'll ask you, are they doing any better? So you go back and you listen. And if you don't hear anything, you need to let the physician know, I don't think they're getting any better right now. And they'll have to go back and, of course, check to see what's going on. But if you go back and check and you listen, they're still wheezing, but they're so loud, then that's a really good sign that the airways are starting to open up again. Because when you think about a wheeze, like whistling, if you were learning how to whistle for the first time, you'd be taught to make the whistle sound like a higher pitch whistle. You're going to need to purse your lips together really, really closely and make a very, 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 very tiny little opening. So that way you end up with a really high pitched, kind of like a note. And then when you want to make a lower pitched wheeze, you need to kind of slightly open up the opening a little bit more. And so that way, as you get better, you'll know how much you need to open up and how much you need to close your lips to make your wheezes sound like when you're trying to whistle, like your wheezes, when you try to make your whistles sound like, different notes, like high-pitched note versus low-pitched note. So that's the same thing that's going on inside of the airways. The wheezes are kind of like music, and in order to have different notes, you need to open and close the diameter of the airway. Dyspnea with accessory muscles. So accessory muscles, it will usually mean that there's definitely increased work of breathing. Pursed lip breathing and tripoding. Tripoding is also something that's not necessarily has been taught to you. You would instinctively do this when you're having shortness of breath, because with tripoding, you are trying to open up and expand your rib cage as much as you can to help to overcome some of that work that you're having to do to breathe. I mean, we tripod all the time. Say if you, like last time that you were running, like maybe like a PE class or something, you were sprinting or something. Once you finish your sprint, you're either going to lean over, you're going to bend over and put your hands on your knees. That's a form of tripoding. Or you're going to stand with your hands on your hip. With your hands on the hip, that's a form of tripoding that you're, again, just naturally doing to try to make it a little bit easier for you to breathe. So these patients, they do it instinctively. And then on and on and on. It could be a pretty bad case. They go through different stages of asthma. There's like a stage 1 all the way to stage 4. Stage 1 would be the very beginning stage where everything, they're tachypnic. And then as they get more tired, they're now progressing into their later stages. And if you don't act fast enough, and we've seen this before, this was back in the 275 course when we had an ABG. And the question was, when would you consider intubating? At what time would you consider intubating based on the ABGs that were collected? And that was like a 22-year-old asthmatic, I think, if I remember, who was going through those different stages from stage 1 all the way to stage 4. You don't want to wait until stage 4 because by that point they're tired and the CO2 is now really high. And then these other things here, cough with sputums. Again, the sputum is not nasty sputum. It's just usually like white or mucoid type of sputum. Because of the air trapping, if you were to tap on the chest with your diagnostic percussion, it would be hyperresonant in quality. Hyperresonancy means that there's not going to be much vibration. So the vocal primitives, if you're listening, if there's a lot of air, you're not going to hear a lot. And there's not going to be a lot of vibrations because sound travels fastest and best through solids than it does through liquids and gases. The prolonged expiration, that's just, of course, longer E time. Our normal E ratio is like 1 to 2, but when you're experiencing this kind of problem, your E time or your E phase is going to have to be extended to try to empty everything out. The pulsus paradoxus, this is the fluctuation in blood pressure. So, well, let me finish this off. Fluctuates due to the air trapping. And what that means is because of the air trapping, when you breathe in, your intrathoracic pressures are even higher than they should be. And then that will temporarily decrease your blood pressure. And then when you exhale, the intrathoracic pressures are not as high anymore, and the blood pressure will go back to where it was before. So that's the paradox. In other words, when you breathe in, your blood pressure should not drop that much as it would in this case, unless there is something that's creating a way more pressure inside of the thorax. And the only thing that it could be would be air trapping, because this is not somebody on the ventilator. It's just someone who's just breathing normally. And then you've got this kind of paradox going on with their blood pressure. So that has to be linked to the air trapping. Now, diagnosis, of course, history. Now, the thing about history, they found some interesting things over the years. They've seen some connections between, first of all, patients who can't really take aspirin, they don't tolerate aspirin. Those patients typically end up with asthma. And another thing they found, which was kind of odd, is if you're not tolerant of aspirin, you will sometimes also end up having what they call these nasal polyps. So if you look into their nose, they got these growths that are happening. And all of that somehow was traced back to asthma in some way. So they look into the history and look for things, and then the pre and post bronchodilator study, this was our greater than 12% and 200 milliliters or 0.2 liters. If you get greater than 12% change in FEV1 and greater than 200 milliliters or 0.2 liters, then that is definitely saying asthma. The bronchoprovocational or methacholine challenge, If the patient is in the physician's office and they're not necessarily having any wheezes, but every time that they go home, they do start to have wheezes. The only time that, I mean, the only way they can reproduce this is to purposely try to get them to have bronchospasm, which is what this test would be. And I already mentioned like what they're looking for as far as the change in FEV1 or the drop in FEV1 that they would consider to be significant. And they also look at labs, of course, increase in the IgEs is going to be a clear sign, as well as the eosinophil count. All right. Now, the X-ray, you won't, let me say this. If let's say you were doing your clinical simulation and they're giving you some information and then they're asking you to do some information gathering. They're asking you what it is that you want to assess and evaluate. And you have to go down the list, as you know, and choose these different things like check the vital signs and et cetera. Now, if they give you the option of choosing an X-ray or checking an X-ray, just know that your X-ray is probably not going to show you anything for an asthma patient. It just really depends. And you may end up losing points for that. Think about X-rays when there's clearly some kind of significant clinical change that's happened. Before they were okay, and now all of a sudden they've got this extreme, maybe case of shortness of breath or chest pain or something that you would be suspicious as far as this may be a pneumothorax now, or they may start to have, like they may have a pleural effusion or something like that. That's when the NBRC wants you to think about ordering a chest X-ray, not for somebody who you may think has asthma. But these X-rays are here just to kind of show what they're referred to here. Increase in the barrel chest, the increase in the AP diameter, and more air means darker, which will be, this is the translucent that they're talking about here, the radiolucency. And then again, the diaphragm would be a little bit more flatter. So with this picture right here, a 64-year-old woman, she has asthma. And the one on the left is showing that she's got some hyperinflation. So you can see that there's definitely the translucency there. There's I guess the increase in radiolucency, but she's also got some infiltrates going on. They didn't mention anything about the infiltrates, and which is possibly atelectasis that's going on. And then the one on the right side, she's in remission. So it looks a little bit better, but the only thing that we can clearly detect as far as the difference here, here's the diaphragm here. And then here, her diaphragm is back to where, so in other words, major air trapping on the left, and then on the right, looks like no air trapping, or not as much air trapping, I guess we could say. Okay, now how do we treat asthma? Of course, if it's obvious what your triggers are, you're always expected to stay away from them, especially if it's something that you can avoid. Some things you just can't avoid, but other things you possibly could, especially if it's like something maybe like a certain food that will trigger. And then your rescue inhaler will definitely be helpful. But your long-term management, your maintenance medication is going to be the most important. So your steroid, if they're taking their steroids every day, good grief. So if they're taking their steroids every day, they may not have to use their bronchodilator, their rescue inhaler, or they have to use it not that often. The leukotriene inhibitors, that would be something that will literally, once they have their allergic response, leukotriene inhibitor is just going to block the leukotrienes so that they don't have as many of the symptoms that you would expect to see in any kind of allergic response. Now, as far as didn't mention it here, but I included a picture of your LABA, your classic long-acting type of combination of bronchodilator and steroid here. Advair was probably the most popular when it was released, but then after Advair, of course, there were others that came along and they did a same kind of combination of a long-acting bronchodilator and a steroid. So we had Semicort, and then there's Dulera, and then there's others out there too. And then there's just Pulmicort by itself, which is just a steroid. But I wanted to just focus on the Advair right here because so many patients are still prescribed this. It's not just for COPDers, but asthmatics will be sometimes prescribed this as well. But the 250-50, 250 micrograms and 50 micrograms, this is going to be a combination, as we know, of we've got Saravan and Flovin. All right, so salmeterol and fluticasone propionate. Which is which? Because this is the standard dosage here, 250-50. But then if symptoms get worse, they may end up having to prescribe a stronger dose. And that would be the 550. Wait, where's the 550? 550? There it is right there. It's blurred out. They made it like on purpose just to focus on the 250-50. But this is the 550. And then if your symptoms are not that bad, they would just prescribe the 150 dosage for you. So notice that out of all three strengths here, all three dosages, the 50 is consistent, but the other number is what changes. The 100 versus 250 versus 500. Now you tell me which one of these is which? Which one of these is being represented? Which is the 250 micrograms and which is the 50 micrograms? Given this little speech I just gave about why they would possibly consider changing your dose or your prescription from 250-50 to maybe 550, or instead of 250-50, they write a prescription for just 150. Now, think about that. It's break time, so let's take our 10-minute break and think about that for a minute or two, and then when we come back, I'll see what you come up with.